Well, good afternoon. I'm Dr. Nathaniel Watson, and I'm here today to speak to you about the diagnosis and treatment of obstructive sleep apnea. And we're also going to spend some time talking about our current study, Cognition after OSA Treatment among Native American People. So, sleep disorder breathing is super common. It can affect up to 30–40% of people. And when you look at these pictures here, you get a good idea of what's going on. On the left side of the slide, you can see we have a non-obstructed airway where the tongue is not falling back and blocking the airway, nor is the soft palate, and there's good airflow. On the right side, you have an obstructed airway. You can see the tongue is collapsing, the soft palate is collapsing, and the mouth is open, and there's just no opportunity for air to get through. And this is quite simply what sleep apnea is. Repetitive episodes of airway collapse that occur during the night that disturb sleep and cause oxygen levels to drop. And when we think about sleep apnea, we're measuring the number of times people have breathing pauses per hour. They need to last at least 10 seconds. We have definitions for apneas and hypopneas. Basically, an apnea is essentially a 10-second period of time where there's almost no airflow. A hypopnea is a 10-second period of time or longer where there's a 30% drop in airflow, and it's associated with a drop in oxygen levels or an arousal on the brain waves on the electroencephalogram. So anyway, we count up all those events that occur during the night, we divide by the total sleep time, and we come up with this apnea hypopnea index, or AHI. And so normal would be anything 0 to 5. So people have events every now and then. It's not it's not necessarily always abnormal. A couple of events throughout the night, no big deal. Mild sleep apnea would be 5 to 15 events per hour, moderate 15 to 30, and severe is greater than 30. So we have both nighttime and daytime symptoms in people with sleep apnea. So from a nighttime perspective, we often get people brought in by bed partners who say that they're snoring or they're stopping breathing in their sleep. The person with sleep apnea themselves may notice waking, choking, gasping, short of breath, that type of thing. Also, nocturia is associated with sleep apnea, needing to go to the bathroom at night. Night sweats as well. Daytime symptoms, typically that's going to be either sleepiness or fatigue or both. People can wake up with headaches that are tension type headaches that improve as the day goes on. There can also be impaired concentration, decreased libido, or impotence and depressive symptoms. So in order to make this diagnosis, we need to have evidence of these sleep disorder breathing events and symptoms such as sleepiness. So we know that male gender, getting older, and being obese are risk factors. And as I mentioned, typical symptoms: snoring, people notice you stop breathing in your sleep, or choking. And then we also see elevated neck circumference. We can see other craniofacial features that we'll talk about here in a sec. The Epworth Sleepiness Scale is something that we use quite commonly. This is a subjective scale that assesses a person's propensity to sleep in 8 different situations. So this is current propensity to sleep. And so the maximum score is 24. Anything kind of less than 10 would be considered normal. The average in the general population is a score of 4 to 8. If you're higher than 10, then that's considered to be evidence of subjective sleepiness. So if when I'm doing an exam and I'm trying to assess if somebody's at risk for sleep apnea, I'll look inside their throat and I can see lateral narrowing. You can see here that you have the very little room for air to pass through, so the soft palate is narrow. We can also see macroglossia, or really large tongue for the mandibular space in which it sits, and that ends up causing tongue ridging or scalloping, where the tongue is pushing in between the teeth, and so you kind of see that when people stick their tongue out. There's also an overjet, so a little bit of space between the lingual portion of the maxillary teeth and the mandibular teeth, the lip side of the mandibular teeth. So that kind of overjet is the thing that we'll see on exam in people with sleep apnea. We'll also see retrognathia, inward displacement of the mandible relative to the maxilla and relative to the nasion, which is the spot in between your eyes. Now, traditionally, for many years, we did polysomnography to diagnose sleep apnea. So this was a gold standard test. It still is a gold standard test. Very involved. You spend the entire night in a sleep lab. You're hooked up to 25 or more different sensors that you can see here. We're measuring brain waves, chest excursion, abdominal excursion associated with breathing. We're measuring airflow at the nose and mouth. We measure limb movements. We have a camera in the room. We're measuring EKG, oxygen levels, monitor a lot of different things for one night in order to establish a diagnosis of sleep apnea. And this is a scrunched up picture of what I would look at when I see a sleep study or a polysomnogram. And really here, what I want you to focus on, so at the top is the brain waves and eye movements and heartbeat. But at the bottom here, this is what I'm talking about. You can see the waxing and waning characteristics of these lines down here. And so when there's not much movement here, those are apneas and hypopneas. This is what it looks like when somebody's breathing for a while and then they stop breathing in their sleep. And you can see the oxygen levels dropping with it down here at the very bottom. So that's classic obstructive sleep apnea on an overnight polysomnogram. Presently, we can use home sleep apnea tests, which has really advanced the field. This is testing that we do on people in their typical home sleeping environment, typically for one night, sometimes for more than one night. And we're not actually measuring sleep. Typically, we're just measuring aspects of breathing or what's called pulse arterial tonometry when people are sleeping. And so let's talk about the PAT. So essentially what's happening there is when you have these respiratory events, when people are not breathing in their sleep, their autonomic nervous system clamps down and it affects the amount of blood flow in the finger. And so the watch PAT is measuring that blood flow as an indirect measure of these respiratory events that are causing or basically the sleep apnea. And so this can be quite accurate and it's very simple. People like it for obvious reasons, and they like being able to do it in their typical sleeping environment. There are other tests as well, some here in the middle at the bottom that are more traditional, where they're actually measuring airflow at the nose, and they're measuring chest and abdominal excursion to assess respiratory effort. Also going to measure pulse oximetry, so it's more of like a stripped down typical PSG. Again, there's no EEG, there's no measurement of actual sleep. And then you have the sleep image ring on the left, which is a photoplethysmography device, which has signals there that can be assessed for the presence of sleep disorder breathing. So there's lots of different home sleep apnea tests that can be used, and they really simplify and reduce cost in regards to the diagnosis of sleep apnea. This is a picture of the entire night of a watch PAT study, and not to get into it in too much details here, but you can see all of these, it's identifying all these respiratory events. We look at the pulse arterial tonometry amplitude. We look at the raw signal. We're looking at snoring, body position, and oxygenation in order to arrive at our diagnosis. So I alluded to this previously, but let's talk about it for a minute again. So an apnea is a 10-second cessation of airflow. It can be longer than 10 seconds. Hypopnea, 10-second cessation of airflow or reduction in airflow, not cessation, but accompanied with a 30% reduction. So again, AHIs, apneas, hypopneas divided by the total sleep time. We also look at the lowest oxygen saturation, and we often look at how much time is spent with an oxygen saturation below 90%. The RERAs are even more subtle than hypopneas. They're called respiratory effort-related arousals, and that can be where there's a much more subtle reduction in airflow, and it's associated with sleep disturbance when we look at the EEG, and so that's a RERA. So how do we treat this? So we always, would think about conservative treatments, which would be avoiding sleeping on your back, keeping nasal passages clear, avoiding alcohol before bed, and avoiding sleep deprivation because all those things can make it worse. How do you avoid sleeping on your back? You can sew a tennis ball in the back of your pajamas, or you can even buy sleep shirts that have bumps in the middle that make it uncomfortable to lay on your back. We have positive airway pressure, which essentially is a mask connected by flexible tubing to a machine that sits at the bedside that just pushes in pressurized room air. And it's basically a stenting the airway open so that the person can breathe in and out without difficulty. So it's very simple. Dental appliances are custom fabricated by dentists that move the lower jaw forward in relation to the upper jaw. They pull that tongue base away from the airway. They tighten up the soft palate, and that can be effective as well. There are a number of surgeries that can be done, and I'll go into that in a bit more detail here in a minute. And then there's some exciting new medications that was recently FDA approved and some that are in development that we may have at our disposal in the next couple of years. Why do we treat it? Well, we know we can improve sleepiness, we can improve daytime quality of life, and improve sleep quality at night. We can also improve morning headaches that are related to sleep apnea and reduce snoring. We know sleep apnea causes high blood pressure, and treating sleep apnea typically with PAP can reduce blood pressure. Usually not to the point where a person would be able to come off their antihypertensives, but nonetheless, it has been proven that treatment of sleep apnea can reduce blood pressure. And as a field, we're still in the process of proving that treating sleep apnea can prevent heart disease and stroke. If you look at, the adjusted odds ratios for high blood pressure here, what you can see is when you look at the baseline AHI compared to 0, even what we would consider to be in the normal range here at 0.1 to 4.9 did show an increased adjusted odds of high blood pressure, which did have a dose response relationship here as we go higher on the apnea hypopnea index, indicating more severe sleep apnea. The adjusted odds ratio of developing and having hypertension go up. This is also true for coronary heart disease, heart failure, and stroke. This dose-response relationship showing that for these particular diseases in this study, an AHI greater than 11 was associated with greater risk of heart disease, heart failure, and stroke. So PAP is the gold standard treatment for sleep apnea, and it's shown here in this picture. It has to be a closed system because it's the pressure that matters. Typically, we don't add additional oxygen in. It's just pressurizing the airway like a pneumatic splint or a balloon in the airway to pump it up, to keep the tongue from falling back, to keep the soft palate from falling back, and to allow people to breathe in and out without difficulty. Very simple and works really well. These are some typical CPAP machines. We talk about CPAP, that's continuous positive airway pressure. That's when we prescribe a single pressure, like let's say 10 centimeters of water pressure. So that's the amount of pressure necessary to lift a column of water 10 centimeters. There are APAP machines, auto-titrating PAP machines that can auto-adjust the amount of pressure they give you within a set range, depending on how much airflow limitation it detects. There are BiPAP machines that provide a higher pressure when you breathe out than when you breathe in, and that can help ventilate people. For some, that can be a little more comfortable. But anyway, there's had been 3 major manufacturers, ResMed, Respironics, and React Health. Respironics has recently gotten out of the business, and so we have the ResMed machines and the React Health machines that we use predominantly in the United States. There's all different types of PAP masks, brands and options, but really there's three main types. So here on the left, you have a typical nasal mask that's covering your nose with a seal around it. And then on the bottom, we have nasal pillows that go directly into the nostrils. And so people that wear glasses at night or they don't like things on their face, maybe they're a little claustrophobic, they seem to like nasal pillows, lots of people like that. And then you have people that are kind of obligate mouth breathers. They like to breathe through their mouth and their nose at the same time. And for those folks, we have these full face masks like this. So does PAP work? It really does work to improve sleepiness and other symptoms, increasing alertness, improving sleep quality, those types of things. As I mentioned before, it can improve high blood pressure, but we're in the process of trying to prove that we can change cardiovascular outcomes or improve cardiovascular outcomes or mortality by treating sleep apnea. Uh, there was a recent study by ResMed suggesting that mortality is improved with treating sleep apnea, and there's evidence there, but we are still researching this area. So how to start PAP? A lot of times we use PAP auto titration. So as I mentioned before, I might set a machine between 5 and 20 centimeters of water pressure, which is a really wide range. And then the machine can adjust itself automatically throughout the course of the night. And the goal there is to expose the patient to the lowest average pressure throughout the course of the night to make it as comfortable as possible. And then in some instances with more severe sleep apnea where there's more hypoxemia or other complicating factors, maybe there's hypoventilation, there's carbon dioxide retention, or comorbid pulmonary disease. In those instances, we may do a sleep laboratory titration where we bring people into the lab, we have them sleep, we have them on PAP therapy, and we adjust the settings while they're sleeping to find the best settings and the best PAP modality to take care of their sleep apnea problem. So there are, issues that come up as people embark on their treatment journey with PAP. Nasal congestion can be an issue for some folks, so heated humidification can help with that, as can nasal steroids. Mask leak is always or often a problem, so working with the durable medical equipment company to find a proper fitting mask that's comfortable and getting it adjusted properly is important. Oral air leak, this can require patients to wear a chin strap or to wear the full face mask I showed you previously. Claustrophobia can require some desensitization. Sometimes we have patients wear the PAP while they're awake, while they're relaxing, reading, listening to music, watching TV, whatever they might be doing in order to get acclimated to it. People complain about difficulty exhaling. We can make some adjustments to the machine settings to improve that. But if it becomes problematic to a sufficient point, sometimes we switch people to a bi-level PAP machine, which is a higher pressure when you breathe in than when you breathe out, and it approximates maybe a normal respiratory cycle. And then we just try to educate people as much as possible because most people aren't necessarily excited about the idea of PAP, but once they start using it, they feel better and they love it. Dental appliances are also an option to consider. It doesn't work quite as well as PAP, but works well. These are inserted into the mouth and they move the lower jaw forward in regards to the upper jaw. So they advance the mandible essentially. These can be custom fabricated and they can be adjustable. You can also buy them over the counter, but generally speaking, we prefer when patients get them fabricated by dentists that are knowledgeable in dental sleep medicine. Downsides, it can cause a little bit of tooth movement over time, can cause a little bit of jaw tenderness when you wake up in the morning, and you typically bite on a little splint that kind of puts your jaw back in place. Some drooling can happen at night, but they're pretty well tolerated. So, they definitely reduce snoring and they reduce the apnea hypopnea index in over half of individuals to less than 10. So it's not completely resolving the problem, but it makes a big improvement. And it can also improve sleep quality and reduce subjective sleepiness. And long-term compliance is a little over 50%. Then we have a number of different surgical options that can be looked into, what we call Powell-Riley phase 1 and phase 2 surgery, and we'll go through a few of these here. Uvulopalatopharyngoplasty, or UPPP, is when somebody, maybe they have tonsillar tissue and a lot of redundant soft palate tissue, so you remove that tissue here and you can see you end up with a more open airway as shown in this picture for this individual. And so this can improve snoring. It typically improves but doesn't cure sleep apnea, so just think about that. And that's true for most traditional surgeries, other than one that I'll touch on in the future here. A uvulopalatal flap procedure is similar to the uvulopalatopharyngoplasty, but it's just a little adjustment on how it's done. And in this instance, if it ever wanted to be reversed, it could be reversed, although I've never heard of that happening. Genioglossus advancement is a way to pull the tongue away from the airway by pulling forward its insertion onto the mandible, and you can see that shown here. And so this is a picture of what that looks like. A window is cut in the mandible, it's pulled forward and then rotated 90 degrees and reattached. This will fill in with bone eventually, and so this tightens up the genioglossus or tongue muscle and keeps it from the airway. And then we have maxillomandibular advancement. Now this is a very involved surgery, but when it's done, it can be curative 80% of the time. Here you're basically fracturing the maxilla and mandible, and you're sliding everything forward in order to open the airway. And so you see that on these sagittal images here, pre-surgical, even when they're not sleeping, just standing there, you can see that there's not much room in this airway. And then after the surgery, you can see a much bigger space here to breathe, and you can see the changes that this has made to the individual's profile. Inspire is something you may have heard about. This is a newer surgical option. This is basically what's called a hypoglossal nerve stimulator. We have basically a power pack that's implanted below the skin. You have a wire that goes between your third and fourth rib to monitor when you're breathing. And then you have a wire that goes, this is all under your skin, goes up under your skin and wraps around your 12th cranial nerve. And what happens is you have a remote control that you can turn on at night, and it flexes your tongue muscle at just the right stage in your respiratory cycle in order to keep it from falling into your airway. So it's flexing your tongue over and over and over again throughout the course of the night. Now, typically, in order for insurance to pay for this, you have to fail PAP therapy. You can't be excessively obese, and you can't have central apnea, which is when your brain's not telling you to breathe. That's different than obstructive apnea, when you're essentially airway is blocked. So that's Inspire. And then we have some medications. Tirzepatide, also called Zepbound, is a GLP-1 medication that's effective for weight loss. And there's a recent clinical trial published showing that this can improve sleep apnea fairly dramatically. So we've always known that weight loss improves sleep apnea, and so it's not surprising that medications that are effective at helping people lose weight would also be effective at reducing sleep apnea. And then there's an oral agent called AD109. We're waiting on phase 3 clinical trial results here. This is a medication that increases the muscular tone in the throat. And that's one of the reasons people get sleep apnea is that we have a bunch, in addition to the tongue, we have a bunch of other muscles in our throat that have to work when we sleep in order to hold our airway open. Some of us do that better than others. Those of us that don't do it very well, we have a propensity to get sleep apnea, and AD109 could help address that. So yeah, I mean, as far as therapy is concerned, typically we'd go with PAP therapy first. It's the best studied. It's the gold standard treatment. It works really well, and it's reversible without long-term side effects. We also discussed the surgical options I mentioned, the traditional surgeries, as well as Inspire with patients. Dental appliances are options, and they're actually particularly effective in people that have sleep apnea that's predominantly present when they're sleeping on their back. So we look at that as far as suitability for dental appliances. And we're usually looking at more mild to moderate sleep apnea for dental appliances. We don't think it's going to have a huge effect on more severe sleep apnea. And then the medications I mentioned, the tirzepatide, also called Zepbound, the GLP-1 medication causes weight loss, will improve sleep apnea. And then AD109, the medication that improves muscle tone in the throat. Let's talk a minute about our catnap study that we've been running in your community and we're really proud of, and we're excited to continue this work. So this is cognition after obstructive sleep apnea treatment in Native American people, and we're focused on the relationship between OSA and sleep health. What we want to do is learn how sleep health relates to brain health, such as Alzheimer's disease and related dementias. And the catnap study is split into two phases. We have an observational study where we're testing many members of your community to assess what's the prevalence of sleep apnea in your community. And then we're looking at a randomized controlled trial to see what impact this would have on PAP utilization in people with sleep apnea. And so the observational study visit takes about 120 minutes. It involves a physical exam and a number of surveys and brain health screenings. There's a saliva sample. And then we do the WatchPat home sleep apnea test to test for sleep apnea. And our goal is to recruit about 450 people for this study, and we're a little over halfway there at the moment. For the observational study, you can participate if you self-identify as American Indian, if you're 50 years of age or older, if you live in either of these Sioux tribal communities for 50% or more in the past year, if you're a known tribal member, or if you live in the household of a known tribal member and have lived in the household for 4+ nights during the past week. And there is a payment of $75 for participation. For the randomized controlled trial, what we're trying to do is assess the impact of something called motivational interviewing on OSA in PAP machine use. This is going to take 9 months to complete. There will be 3 study visits at a cadence of 1 visit, and then another one 3 months later, and then another one 9 months later. The first and third visit take about 2.5 hours, and the second about an hour and a half, and we're expecting to recruit about 150 people. So you can participate if you self-identify as American Indian or Alaska Native, you're 50 or older. Again, you live in these tribal communities, diagnosed with OSA, you have a prescription for PAP therapy, and you've been using it for fewer than 60 days since first use, or more than 60 days, but you haven't met Medicare guidelines for treatment adherence, and you're willing and able to follow study protocols. So there's 3 study visits and compensation of $180 for participation. If you're interested in either one of these studies, please contact these individuals here at Missouri Breaks. Lindsay and Leslie would be more than happy to discuss the study with you in more detail and get you enrolled. So we really hope that you will participate with this on that. And with that, I will wrap up my talk, and I appreciate your time and attention. Thank you.